Hello, everybody. I recorded 2 hours of footage and it all was muted. So really quickly, I'm going to blitz through NBME 29, all original questions, everything you need to know. We're going to go from 23 all the way to 50. Again, just wanted to preface, these questions are completely original. They do not replace the NBME. They're not copied from the NBME. It's totally separate from the NBME. This is just an additional study resource to help you feel prepared by the time you take step one. All right, let's dive into it. In this question, we have a 70-year-old man undergoing resection for stage 2 pancreatic cancer, enrolled in a long-term prospective trial tracking postoperative survival. The lab below shows the proportion of patients alive at the start of the year and how many survived through the following year. All right, and then it progresses through, and they're asking us, hey, what's the probability he'll survive through year 4? And the answer is literally just C. It's exactly this value. Now, what's interesting is this is a Kaplan-Meier Survival Curve, and this is a non-parametric statistical approach where you just analyze the time to event data, and it's used for survival analysis. Parametric would be like a t-test, ANOVA, linear regressions, right? You assume normality, linearity, all that stuff. Non-parametric is the Kaplan-Meier survival curve, like in this question. So really easy. Parametric just means you're fitting your data to a mold. Non-parametric is you're just letting the data decide the mold. And that in itself is even overkill. All you need to do is just kind of look at this little table and say, okay, year 4, it's here. Boom, boom. When you're dealing with biostats, I had somebody ask me, hey, can you do biostats questions? And I said, yes, soon. Biostats, don't overthink it. Just memorize the formulas and then have the confidence to be able to select the answers because they're usually pretty easy or they're formulaic. They don't expect you to do large calculations. That's biostats. Next. All right, in our next question, we have a 5-year-old girl brought to the clinic for swelling around her eyes and abdomen that developed over the past week. Her parents report she had mild upper respiratory infection 2 weeks ago, and someone updated the image to show like a young boy or young girl. You can see right there in the image. That's the demographic we're talking about. And on exam, we have periorbital edema, distended abdomen, shifting dullness, and normal blood pressure. Urine analysis shows 4+ protein with no hematuria. Serum creatinine is normal. Albumin is 1.6. Cool. And this is the most important part, I think, reveals widespread effacement of podocytes foot process. This is minimal change disease. Now, the case breakdown here is definitely going to be you do not have blood in this disease. It's proteinuria, hypoalbuminemia. What does that mean? That's when you have low levels of albumin in the blood. And it causes the fluid to leak out of the blood vessels and accumulate in other body tissues. All right, so you're gonna have like the swelling in the legs, the abdomen, the lungs. And this is usually because of like a liver disease or increased loss, like in kidney disease and even burns. And the treatment is really just focused on managing the root cause. So hypoalbuminemia is going to be minimal change disease. And on light microscopy, this is super, super important. It looks totally normal. If you see normal on light microscopy and you see effacement of the podocytes, click it, move on. That's super easy points on test day. And it responds super well to steroids. Alport syndrome, hearing loss is what you'd see with that, splitting of the GBM. Yeah, focal segmental glomerular sclerosis. This is going to be super common in Africa descendant HIV, but you would see segmental sclerosis, not minimal change, hence minimal change disease. Membranous nephropathy, that's another nephrotic syndrome, and it's thickened GBM. And also you have the subepithelial deposits in adults. So minimal change disease, really think of in the children. And IgA nephropathy is hematuria post-infection. All right, in our next question, we have a 42-year-old woman undergoing exploratory laparotomy. Laparotomy is an incision into the abdominal cavity in preparation for surgery. It's given under general anesthesia. During the procedure, she receives intravenous medication to facilitate relaxation. Breathing ceases despite preserved spontaneous phrenic nerve firing. Her pupils are reactive and all that stuff. However, no thoracic abdominal excursions are noted. Which of the following drugs was administered? Pacuronium is the answer. So the setup in this question, and I'll zoom in to my notes when I did this the first time, is the airflow is stopping, right? And the diaphragm is not moving. And the phrenic activity is still continuing, right? So what does that mean? That means that the brain and the nerves are still firing. But the abdominal pressure, that stops changing. What does that mean? The muscles are not responding. So here's like the key logic. If the nerve signal is still firing, but the muscles don't move, then the block has to be at the neuromuscular junction, right? And that's postsynaptic. So that's exactly what a non-depolarizing neuromuscular blocker is going to do. And so, boom, there's our answer. We pick our non-polarizing neuromuscular blocker, and it competitively inhibits acetylcholine at the nicotinic receptors in the neuromuscular junction. So the phrenic is going, diaphragm can't contract. Succinylcholine would have initial fasciculations. It's a depolarizing blocker, so you'd have brief muscle activity before paralysis, not just cessation prior to motion. Propofol, that depresses the CNS. Nerve activity would be decreased with that one. Fentanyl, opioid, they said they didn't have opioid signals, right? Opioids, barbiturates, those guys would depress the CNS anyways, and so that would cause the phrenic nerve to go down. Halothane, it's a volatile anesthetic, causes CNS depression. They could give you other things, tetrodotoxin, lidocaine, right? Those guys will block the nerve or just like kill the heart, right? The phrenic nerve activity also would decrease or disappear. And then non-depolarizing blockers like tubocurarine, coronium, those guys Those medications allow the nerve to still be active, but the muscle is paralyzed. Non-depolarizing blockers, right? And so just thinking about this practically, like your nerve is firing, acetylcholine is released into the neuromuscular junction, and then acetylcholine binds to the nicotinic acetylcholine receptors on the muscle end plate. And this opens the ion channels, and that lets the sodium go in, the potassium go out, and then that causes end plate depolarization. Depolarization spreads and the muscle contracts. Well, non-depolarizing blockers like tubocurine, rocuronium, bracuronium, those are competitive antagonists at these nicotinic acetylcholine receptors. And so the acetylcholine can't bind, and so there's no depolarization. And the muscle is then flaccid and paralyzed. So the nerve activity is still normal, right? The phrenic nerve is still firing, but there's no muscle contraction. And it's reversible with acetylcholinesterase inhibitors. So what's an example of how this is reversible? Neostigmine. So more acetylcholine would then flood the synapses and it'll outcompete the blocker. If you give them acetylcholinesterase inhibitors, it stops the breakdown, allows more of it so they can flood and outcompete this blocking stuff. All right. So yeah, acetylcholine is an acetylcholine receptor agonist, right? It binds and opens that channel. It causes persistent depolarization and the muscle can't repolarize. So it stays paralyzed. Those are depolarizing blockers like acetylcholine. Maybe another way, I don't want to like beat this dead horse, but like think of it like a lock and a key. Non-depolarizing, that's like a fake key jams the lock and the real key can't get in, right? So the door is going to stay shut, also known as paralysis. Depolarizing would be the real key gets stuck in the lock and it's just not going to be able to reset. There's no contraction. I don't know, maybe that's too simple of an example. Non-depolarizing, they sit right there. Antagonist, blocks acetylcholine, muscle never depolarizes, flaccid paralysis. And then the depolarizing blockers, those guys act like acetylcholine. They bind that receptor a little bit too strongly, and they cause big depolarization fasciculations and they stay stuck. So you can't reset them. So it's also paralysis. Depolarizing, non-depolarizing. All right, in this next question, here the demographic can change. I think in the previous practice question that I made when I recorded this the first time, it was a 75-year-old, hence the photo. In our practice question now, we have a 30-year-old preschool teacher presenting in the clinic in January, 2 days of fever, cold, fever, chills, headache, sore throat, body aches. Rapid antigen test confirms influenza A. She started on oseltamivir. The drug most likely prevents which step in the viral life cycle? All right, so the way that the virus works, the influenza life cycle, is the virus uses hemagglutinin to bind nucleic acid on the epithelial cells, and that's how it gets inside. And it's inside the nucleus, then the viral RNA is replicated, and now the virus buds outside of the cell membrane. But first, it's got to get in with hemagglutinin to bind the sialic acid on the epithelial cell. But yeah, eventually later on, new viruses, they bud out, but they're stuck on the host cell, right? They're still bound to that sialic acid. And so neuraminidase, and it cuts it and frees it. So if you give them neuraminidase inhibitors, like oseltamivir, then it will block that step, blocks that step so they can't get out. Sialic acid can't be cut. The infection does not spread from cell to cell, and the symptoms are going to get shorter and the illness is less severe. So you're blocking the release of that virus from the epithelial cells. And so if we look at our question, our answer is indeed going to be the cleavage of the surface sialic acid residues. All right, there's our explanation. Neuraminidase cleaves sialic acid residues, freeing the budding virions. Oseltamivir inhibits that, trapping them inside, limiting the viral spread. Fusion is hemagglutinin mediated. Transcription of RNA's negative sense into mRNA is done by the viral RNA-dependent RNA polymerase. Assembly of nucleocaspid in the cytoplasm. Influenza replicates it. And translation of the viral polymerase proteins. Translation is host ribosome mediated and occurs before the budding. All right, now this one is actually super duper simple, so I don't want to harp on it too much. Broken hairs of varying lengths. Trichotillomania. Irregular patches of alopecia. Now this is often seen in obsessive compulsive disorders, repetitive tension relieving behavior. It's a female predominance. Hence our demographic over here with our generated image as comorbid with anxiety. And basically in this condition, we have physical stress and anxiety, repetitive hair pulling, tension relief. And so now how would this present in a question? Well, here we have a 12-year-old girl brought to a clinic due to patchy hair loss. And so you immediately know that it's going to be D. Irregular hair loss, broken hairs of different lengths, and also emotional distress, recent bullying, right? And this is an impulse control disorder. Now, why is not all these other answers? Fluvium has diffuse hair shedding. It's not going to be the patchy and broken. Androgenic, progressive thinning. Hernia capitis, scaly patches. The black dots, alopecia areata, smooth circular patches. So really, it's just the nature of it. And that's why I wrote this when I recorded for the first time, varying lengths. That's the huge deal there. Varying lengths. That's all you need to know for this one. All right, moving on to SGLT1s, 28. So now we're going to see this in a cute little baby. In this case, we have a 2-month-old girl evaluated for persistent watery diarrhea and poor weight gain. She's exclusively breastfed. Physical exam shows irritability in dry mucous membranes. Lab reveals metabolic acidosis. Stools demonstrate low pH. Oral glucose challenge is given. Serum glucose does not rise. But when you give fructose, diarrhea improves. What mechanism is deficient? The answer is indeed C. Sodium glucose co-transport in the enterocytes. So we got a little youngster, right? Breastfed. And so lactose which is comprised of glucose, galactose, and you have watery acidic diarrhea and reducing substances in the stool. Why? Because the sugars are not being absorbed. And so oral glucose is not changing the sugar, so the glucose is not being absorbed, but the fructose is fine, and the fructose pathway is intact. That tells us that GLUT5 is working, because that's going to be our fructose pathway. GLUT5, all good to go. So the key physiology here is that there's glucose and galactose absorption via the SGLT1, right? And that is a sodium-dependent transport. And fructose absorption via the GLUT5 is independent of sodium, and so it's fine. So this is SGLT1 deficiency. You can't absorb glucose or galactose, and it causes diarrhea, dehydration, reducing sugars in the stool. But the fructose absorption, totally normal. Now another thing, SGLT1s, these are in the small intestine, in the muscle. Think about it, you have 4 muscly limbs, right? Especially if you're lifting your calcium oxalate dumbbells. Sucrase deficiency shows after introduction of solid foods. Cool? I think this baby is cool. Like and sub if you're doing peds. Peds is the best specialty out there. You guys deserve way more money. All right, next, our demographic has changed. It's going to be an elderly patient. In this question, we have, for instance, a 68-year-old man with a history of hyperlipidemia and mild exertional dyspnea that comes in for routine evaluation. He denies chest pain, palpitations, orthopnea. Physical exam, you detect a late peaking systolic murmur best heard of the right upper sternal border, radiating to the carotids. Carotid upstroke is delayed and diminished. Echocardiogram reveals concentric left ventricle hypertrophy and a heavily calcified aortic valve. What explains this pathology? The answer is a chronic mechanical injury from the valve function. Now, you need to be aware of something called a calcified aortic valve. In my other practice question, I had a 76-year-old male with calcification. And this is going to be seen with a systolic ejection murmur along the left sternal border. So in elderly patients, it's the repetitive kind of microtrauma that happens with opening and closing. And that leads to aortic stenosis, which produces a crescendo decrescendo systolic ejection murmur. And it's common in patients that are greater than 65, let's say, especially have no history of rheumatic fever or congenital bicuspid valve. So this is calcific aortic stenosis, age-related. It's just age. You get obstruction and left ventricle hypertrophy because of that stenosis. You got to pump harder. Post-rheumatic, that's when it's fused, commissures, or mitral involvement. Prior bacterial endocarditis would be regurgitation, not stenosis. Accelerated atherosclerosis would contribute to calcification, but this is just mechanical wear. Amyloid deposition would be restrictive cardiomyopathy. All right, here's our next demographic. Let's say middle-aged man, middle-aged woman. Not too important here. 41-year-old woman here presenting to the emergency department with a 2-day history of persistent right shoulder and upper abdominal pain. Recently lost 30 pounds over 4 months through a low-carb, high-protein crash diet. She's got some nausea, low-grade fever, 101.1 kLRC. Just kidding. Temperature. On exam, she winces and abruptly stops inspiration during palpation of the right upper quadrant. Labs reveal all this good stuff. What's the diagnosis? All right, so the big things that I see in this question, and I've written some notes over here before, is we have some rapid weight loss, right? So here we have losing a lot of pounds in a short amount of time. So that's like a risk of a gallstone. T ratio, right upper quadrant tenderness. That's what we're seeing here. There's no blood in the stool, right? So that means it's not like a GI bleed. But that rapid weight loss increases the cholesterol stimulation to the bile. So like you get more of that cholesterol. And then you get obstructed cystic ducts, and that causes an inflamed gallbladder wall, leading to acute cholecystitis. So that's the right upper quadrant pain, leukocytosis, biliary lab stuff. And there are a couple of answers that you should always be thinking about with these types of questions. And one of them is acute pancreatitis, and that would have elevated amylase and lipase levels. It's super important to know those two lab values for acute pancreatitis. Small bowel obstruction. There's no signs of obstruction. That'd be like a prior surgery or distension. Hepatitis A would be recent travel, jaundice, malaise, all that stuff. And gastritis is NSAID use, alcohol. Gnawing epigastric pain would be gastritis. They could also say things like try to get you on GERD. GERD would be seen with a burning chest epigastric pain, not right upper quadrant pain. Burning epigastric, GERD, give them a proton pump inhibitor. You could also be seeing, or on tests they might ask you about like a fatty liver, and that's usually just completely silent or even chronic. There's no leukocytosis or anything like that in the fatty liver, or a peptic ulcer they could get you on, and that's pain, GI bleeds, a cold blood, and that's not going to be seen in this patient, right? The peptic ulcer would maybe cause some bleeding. So fat, female, fertile, 40. And if you wanted to, you could even add fat weight loss, right? That's an extra risk as well. All right, next we have a 64-year-old woman with advanced multiple sclerosis admitted to long-term care facility, recurrent hospitalizations of urinary tract infections, wheelchair bound, has difficulty moving her lower extremities. Physical exam, she's alert, minimally interactive. BMI is at 19. What's most effective in preventing skin breakdown? The things to look out for on test day for this condition is going to be paraplegia. So somebody is like immobile, usually, is how they'll ask this. They're admitted with a urinary tract infection, and you're trying to prevent the skin breakdown. So you should think of Decubitus ulcers, right? That's skin breakdown from prolonged pressure on bony sites. Where are your bony sites? Well, it's like your elbows, right? Your scalp, your heel, your sacrum. So the mechanism is increased pressure. This is really interesting. Increased pressure causes a decreased blood flow. That causes ischemia, that causes tissue death, that causes ulcers. This question is really actually kind of a good one because you're trying to protect the ulcers. You don't want the ulcers to happen, but you have to recognize that this person is a long-term care facility, wheelchair bound. They're sitting on their butt all day, right? And they have a lot of pressure points at the bony sites. And so that bony pressure causes less blood flow, causes that ischemia, and that causes tissue death. So really a really good question here. And you need scheduled turning and repositioning. So the answer is C, you got to reposition. Just because of the low BMI does not mean high protein malnutrition. You should instead think about what the question's exactly asking. Topical antibiotics, that would treat the infection, not the ischemia. Barrier cream helps with moisture, but not preventing necrosis caused by ischemia. Antiseptic washes, nah, that would not prevent ischemic ulcers. And now this is actually really slept on. Like not a lot of people, no pun intended, I guess. But yeah, it's about over 2.5 million patients in the US develop pressure ulcers every single year, and many of them are entirely preventable, right? So if you guys are rounding on a physician someday, you should be like, hey, have you moved from that position in a while? Like, let's move you. Let's get the blood flowing. But maybe some other things they might try to get you on would be like arterial blood flow, and that'd be for like vascular disease ulcers, not pressure ones. They could also get you on nutritional stuff, right? That'll help the healing, but it's not going to stop the ulcers from forming. They could also get you on like bacterial skin flora stuff, right? That's bacteria that infects the ulcers after they form, but it's not the actual cause of it. Or like venous stenosis. And those are just different types of ulcers. So they're going to test you on different ulcer types. You just need to know that it's a pressure ulcer. All right, going to hide the answer here and move on to 32. 64-year-old man, 15-year-old history. So different demographics here. Female could be as well, around the same age. But we got poorly controlled type 2 diabetes. Chronic fatigue, bone aches. Look at that phosphate. It's high, should be 2 to 4-ish. So phosphate, then maybe there's a kidney. Oh yeah, look at that creatinine. Holy cow. Big old kidney problem, BUN. All right, so what's the abnormality thing going on here? Well, definitely we're having trouble because we have kidney problems, right? It seems like there's kidney problem that's causing secondary hyperparathyroidism. And so our answer is going to be C. Let's talk about this though. So in the other question I recorded, I had a 58-year-old female. In this question, we have a 64-year-old man. So the kidneys make vitamin D. And that's kind of crazy, right? Because it makes you think of like the calcium of it all. And that it's helpful because in renal failure, you have decreased vitamin D and decreased calcium absorption. So calcitriol being vitamin D is helpful. But yeah, it helps the gut absorb the calcium. That's the whole role of the vitamin D. That's one of the reasons why the kidney makes it. Phosphate is like the trash, get it out of there. So in renal failure, you have decreased vitamin D. So that causes hypocalcemia because you don't have that calcitriol. So you can't absorb the calcium. And also the phosphate excretion decreases. So you have hyperphosphatemia, more of it. You're like, oh my gosh, too much of it, can't get rid of it. Hypocalcemia, hyperphosphatemia, that stimulates the parathyroid gland, causing secondary hyperparathyroidism. And so on the labs, you'll see low calcium, high phosphate, high PTH. And now the question that I usually get, and I'll allow you guys to kind of see my beautiful face and my room. Check it out. By the way, I'm doing this because you guys told me that you'd prefer this over the green screen. Let me know if that's still the case, because the green screen's kind of fun, But anyways, you might be wondering, okay, why does the PTH go up in chronic kidney disease? The kidneys normally help the calcium and the phosphate be balanced, right? So you convert the vitamin D, calcitriol, we talked about this. Well, in chronic kidney disease, we obviously don't have calcitriol. So the gut does not absorb as much calcium. And so there's hypocalcemia and there's no phosphate excretion. And what's kind of even worse is that this extra phosphate that's just like in our body is going to bind the free calcium. And that then lowers the ionized calcium even more. And then the parathyroids are like, oh my freaking gosh, we have low calcium here, and that's our one job, right, to keep the calcium normal. And so we need to secrete more parathyroid hormone. And so that's secondary, not caused by like some tumor or something there. It's secondary to the other issue of the kidneys. Secondary hyperparathyroidism, PTH goes up in response to chronic low calcium and high phosphate. So PTH tries to fix things. It's like, let's increase the bone reabsorption. Let's like stimulate those osteoclasts. Let's release that calcium and that phosphate. And let's stimulate the kidney. Let's also stimulate the kidney. This is PTH speaking, so that we can make calcitriol. But then the kidneys are damaged, right? So that's not going to work very well. And you increase the calcium reabsorption in the kidney. And again, this is limited in chronic kidney disease. And so that PTH is just going to be rising and rising, but the calcium is never fully going to normalize. And so you have persistent high parathyroid hormone, all right? So it's low calcium, high phosphate, high PTH. Hopefully I explained that well. If you guys think this is helpful, please like and subscribe. It takes a long time to make these videos, double time if you forget and do this accidentally. But yes, it's on. It's blue. Okay, good. All right, guys and gals. There was a study that I read recently that said women physicians are like just holistically better than male physicians. They have like better outcomes for patients. And I was like, that makes sense. Anyways, we are on question 33. I'm going to try to speed through these, but our demographic for this question is going to be somebody who's like pretty fit. Reminds me of that Modern Family episode. I want to dance the ballet. 29-year-old ballet dancer presents with chronic right knee pain after high impact performances. Imaging shows thinning of the articular cartilage but no bony involvement. Biopsy of the affected tissue reveals reduced hydration and compression tolerance. Which biochemical feature of normal cartilage molecule explains the ability of to maintain the high water content in physiological conditions? Okay, now on the surface, this can be pretty tough, but like what this question is asking is essentially, why does cartilage via chondroitin sulfate swell and occupy more space in water than it does in a dry solid? And so what we need to know is that there's this thing called chondroitin sulfate. I'm going to zoom in. I've taken notes in this before. This is a glycosaminoglycan, or GAG, as you may have seen it in your med school classes. GAGs have tons of negative charges. In fact, anytime you guys see, there's a little tip, anytime you see sulfate, just click negative charge. It's going to be the answer. I swear, like every single time. I've seen so many times where sulfate is just negatively charged is the answer. And yeah, negativity, right? It attracts lots of water, the hydration shell, right? So you have the negatively charged that repels each other and the molecules spread out, and the negativity that attracts a lot of water. And so that together makes a gel-like space-occupying, shock-absorbing structure that's good for cartilage. And so our answer is high-density sulfate and carboxylate groups. Let's explain this a little better. Chondroitin sulfate is rich in sulfate and carboxylate, so it's highly negatively charged. It attracts water through these electrostatic interactions, leading to repulsion between chains. Hydrated mixture allows cartilage to absorb mechanical stress. Hyaluronic acid does not explain hydration. Lysosomal degradation would be a storage disorder, not water retention. Covalent linkage, it's for anchoring, not swelling. And N-linked glycosylation would be protein glycosylation, not the hydration behavior. All right, so maybe there's a way that you can remember this by saying GAG on water, right? GAGs, GAG on water. Glycosaminoglycans have negative charges, and so they soak up the water, and that gel cushion can form. I want to make this super duper simple. I worry that I overcomplicated this one. Maybe I didn't, I don't know. But basically, chondroitin sulfate has tons of negatively charged molecules. Negative repels negative. That causes these molecules to spread out. Negative attracts water, it swells, becomes gel-like. That's the answer. That's it. They're going to try to be like, oh, but collagen. Oh, you've seen collagen before. What if I said collagen binding? Don't you have to choose that because you know what collagen is? I don't know. Maybe I'm projecting, but that's how I feel sometimes. Structural support, right? Anytime you see collagen, think structure, right? Not swelling. How about covalent bond with core proteins, right? That's how proteoglycans are built. That's not why they expand, right? Covalent bonds do not tell you necessarily about the expansion. And they could try to get you with like the N-linked stuff. They'll say, oh, what about the N-linked oligosaccharides? Well, that's a glycoprotein modification, and it's just going to be unrelated. So GAGs, GAG on water. They have negatively charged, they soak up the water, and they cause that gel cushion to form. Hopefully that makes some sense. All right, next we have a 27-year-old man collapsing while hiking in Arizona. Been exposed to high heat for hours, didn't drink water. His vitals should tachycardia and hypotension. By the way, always drink water. Check this out. It's so good for your kidneys. This is how much you need to drink in a day. It's probably more than you thought, but I digress. Anyways, this could be any demographic. It could be an older woman, could be an older man, could be whatever. So I'm just putting that question demographic up there. But yeah, the serum is 150. Dehydrated state is what we're talking about. And what's most critical in helping to conserve the water? It is the urea transport into the medullary interstitium from the collecting duct. So the answer is C. And a way that you could see this is like, okay, a man or a woman is running a marathon, they get dehydrated. And that dehydration means you got increased plasma. Osmolality is the concentration of a solution as expressed by the total number of solute particles per kilogram. Okay, so you got a lot of the solute. And the brain senses this. The brain's like, oh my gosh, we got a little solute. Let's release the hounds. Let's release ADH, like Mr. Burns. ADH is a fancy little thing. It's also known as a vasopressin. All right, now the main job of ADH is to put the aquaporins in the collecting duct. Chunk, 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 chunk. It just puts them there, right? Hey guys, let's upregulate the aquaporins. It also has a side job, and that side job, it's a side hustle, is it increases the urea reabsorption through the medullary collecting duct. All right, so we're increasing that urea as well, that absorption. And the urea really helps the medulla stay salty, right? The high osmotic gradient. I took a class on like nephrology at Harvard from one of the most foremost experts on the kidneys. And I swear every 5 minutes he'd say, we need to preserve the osmotic gradient of the kidney. So yeah, it's super important that we just preserve that osmotic gradient. And here's our explanation. Dehydration responds by increasing ADH. Not only increases aquaporin insertion for water absorption, but also increases urea transport to the medullary interstitium. The urea makes a gradient, drawing more water out of the collecting ducts and concentrating them. So it's all about that gradient, right? ADH is the main hormone that saves water. It adds water channels to the duct and it pulls urea back into the duct, making the medulla extra salty. And that helps it suck out even more water. All right, so ADH adds water, adds urea. That's how I want you to think of ADH, and we're done with that question at least. All right, we're gonna have to go quickly. Macrocytic anemia, alcoholism, seizure, macrocytosis, hypersegmented neutrophils, low retic count, ineffective erythropoiesis is what that means. So you see macrocytic anemia, low folate intake, rapid depletion, B12. And then the other thing to know about B12 is that it has an increase in both, right? Vitamin B12 deficiency takes years to develop, and you can see both increase in homocysteine and MMA. All right, so for this question 35, the big things to look out for are macrocytic anemia. A retic count is low. That means we're not making red blood cells very well. And there's also alcoholism, malnutrition, that's a vitamin deficiency. And the stores of folate are going to run out super quickly, but then the vitamin B12 deficiency takes years to develop, right? So here we have a 44-year-old woman brought in by a roommate, confused, tremulinous, history of alcohol use disorder. The answer is going to be a folic acid deficiency. Here are the answers and the explanations. They're going to try to trap you various ways. They might say lead toxicity, that's microcytic. They might say iron deficiency, that's also microcytic. Beta thalassemia, that's also microcytic. Thiamine deficiency, they could see like Wernicke's encephalopathy, but that's not going to be a cause of anemia, right? So they could do a whole bunch of things. Vitamin B12 is another one to look out for. But B12 deficiency takes years to develop and folate runs out more quickly. Alcoholism and malnutrition tells you it's probably like a vitamin deficiency. You might be wondering, okay, like folic acid deficiency, vitamin B12 deficiency, which one is like, alcohol is more related with folate deficiency. It's much more common and much faster. And for B12 deficiency, the causes are usually like pernicious anemia, gastric bypass, Crohn's disease, vegan diet. So the stores are a lot less for folate. So it runs out in weeks to months. All right, next we're going to be talking about a 27-year-old kindergarten teacher presents with spontaneous gum bleeding, widespread petechiae, recovers from a cold 2 weeks ago. Here are her labs. What's the underlying mechanism? It's autoantibody mediated platelet destruction. So, might say like a young woman. Here's a kindergarten teacher. You can see our photo. Easy bruising, viral illness a month ago, thrombocytopenia, bone marrow smears, right, which show like megakaryocytes. Viral infection causes, the way that this typically works, this is, by the way, ITP is like a ruling out diagnosis, but you have a viral infection and then the immune system gets all activated and then you start to make antibodies against the platelets. And that is anti-GP2B3A. And so the platelets get destroyed in the spleen, splenomegaly. The bone marrow is still healthy, so it just makes more. And that's why you have megakaryocytes. It's like a good positive response that you're trying to do. You're trying to build megakaryocytes so you can respond to the lost platelets. And this is immune thrombocytopenia purpura. It's an immune problem. All right, they could try to trick you in various ways. Here are some trap answers. Bone marrow failure. That would have hypocellular marrow. B19 is aplastic, splenic sequestration, splenomegaly. But here actually they didn't mention splenomegaly, interestingly enough. But yeah, the sequestration would not necessarily come from a viral illness. DIC, elevated PT and PTT. And just briefly on the spleen, you might ask, okay, so if platelets are being destroyed in the spleen, then why would not the spleen like be the answer or in the answer? And so like this question's going to ask, or a question you might see is, what's the most likely cause of the thrombocytopenia? Well, the cause is immune-mediated destruction of the platelets. And the spleen is the place where the destruction happens, but the mechanism is still antibody-mediated platelet opsonization, and it's the splenic macrophages that clear them. And so if it said like splenic sequestration as the answer, like big spleens from cirrhosis or portal hypertension, well, that's kind of a different mechanism, right? So in sequestration, the spleen traps the platelets mechanically. In ITP, it's the autoantibodies that target the platelets, and it just happens to be the spleen that recognizes and destroys them. Hopefully that makes sense. Think of it this way. Big spleen, thrombocytopenia by sequestration. Normal spleen, recent infection, megakaryocytes, that's probably ITP. I know that can be confusing at times, so I just wanted to kind of point that out. Oh, I should probably have written that down. Big spleen, thrombocytopenia. Normal spleen, recent infection with that autoimmune activation, and the presence of megakaryocytes. And low tells you got ITP, right? Peripheral immune destruction. All right, in our next question, we have a 59-year-old man. Could also be a woman with a 40-pack, presents with new onset fatigue, elevated blood pressure, and difficulty rising from chairs. He denies pain or sensory changes. Physical exam shows moon phase, central obesity, and decreased muscle bulk in the thighs. Fasting glucose at 178. T reveals central pulmonary mass, encasing the right main bronchus. Main bronchus. Which hormone is most likely responsible for the muscle weakness? Oh, and biopsy shows small dark blue cells of chromogranin A. Well, we had moon phases and central obesity, and that tells us it's Cushing syndrome. And that's usually hyperglycemia. You see like, proximal muscle weak, proximal muscle weakness, trouble standing up. But this is kind of a tricky one, right? Because, and also this is important. Like I kind of lit up, you saw whenever I saw central pulmonary mass. And that's because I've made a couple of videos on this, and the last recording I did that was 2 hours long, I went through and I explained all of the lung diseases. I should release the muted version of that because I get so excited when I talk about this because there's a really simple way of not missing questions like this in the future. But here I know that this is small cell, or it's going to be squamous cell if it's central. And so small cell carcinoma can secrete ectopic hormones. So that can kind of explain, the muscle weakness, the hyperglycemia, the Cushing syndrome stuff. And you can have a tumor that secretes ACTH and that overstimulates the adrenal cortex, and that causes the increased cortisol, explaining the Cushing. Isn't this crazy? Like medicine is kind of crazy sometimes. But here, The answer is adrenocorticotropic hormone. And it's because of that ectopic ACTH from the small cell. And here, I think it's like super important to actually look at these answer choices. Vasopressin, inappropriate ADH would cause hyponatremia, not hyperglycemia. So it ain't vasopressin. Calcitonin, medullary thyroid carcinoma, inhibits bone resorption, not with Cushing. This one, PTHRP, that's hyperglycemia malignancy. That'd be squamous. That causes calcemia, not hypercortisol. So that cues you into the different type of cancer. IGF-1, acromegaly. So yeah, there are some tumors that make you diabetic, weak, puffy-faced, and it doesn't even touch your pancreas or your pituitary gland. It's the paraneoplastic syndromes of the small lung cell cancer cell. You should think of PTHRP, parathyroid hormone-related protein, and that one causes an increase of calcium. All right, looks like I did a graffiti all over this question in my last video. This one, aspirin makes it worse. Let's talk about when aspirin exacerbates things. Well, there's something called aspirin-exacerbated respiratory disease. It's associated with chronic rhinosinusitis with nasal polyps. Here we have a 29-year-old woman, but it could be anybody, and especially somebody young. Like it could be like a 15-year-old girl or boy, for instance. That's kind of like this demographic. And they have onset asthma, presents with shortness of breath and wheezing 30 minutes after taking an over-the-counter. So it's aspirin exacerbated, and you just have to know the mechanism of aspirin is cyclooxygenase. All right, so they have non-selective irreversible inhibition of COX-1 and 2, phospholipase A2, steroids inhibit it, 5-lipoxygenase, dilutin blocks it, leukotriene downstream, and prostacyclin is downstream as well. So yeah, aspirin can make asthma worse. So it's important to remember glucocorticoids can block phospholipase A2, but that's like way upstream. And then aspirin and NSAIDs block COX. And then xyleutin blocks 5-lipoxygenase, and montelukast blocks the leukotriene receptors. All right, this next one's pretty easy. It's just an opioid overdose. Pinpoint peoples is what you need to know. Low respiratory rate. There's a triad for opioid intoxication. 23-year-old man unconscious at a bus station. Small bag of crushed pills is found. Withdrawals to pain, does not open the eyes or speak. Basically, he's got a CNS depression, bradypnea. So his respiratory rate is like super low. That's opioids. And so the answer is D. Pulse is decreased, respiration is decreased, pupils are constricted. Super simple. The mental status, you have like a sleepy comatose patient. The breathing is depressed, it's slow, shallow, heart rate is bradycardic, and hypotension, the pupils are pinpoint. That's opioid overdose. I feel like a lot of people know this one. So those are the notes that I took on the last one. And by the way, you give them an naloxone for that. That's the antidote. All right, so here we have a 29-year-old woman, 34 weeks gestation, presents to her primary care physician with a 3-day history of fever, myalgia, loose stools. She denies cough, dysuria, and rash. She has no pets. She ate cheese, fruit platters, smoked salmon, febrile, leukocytosis, catalase positive, gram-positive with tumbling motility. What led to this? It's the eating of the soft cheese. Right, this is Listeria. So the blood culture shows small gram-positive rod. And here it's just a matter of memorizing all of these rods, which is so silly because we can just look them up on the internet. But don't get too cynical yet. Things will change eventually. Fever, nausea, headache. That's what you should look for in this one. Catalase positive, tumbling motility. What else about Listeria? It grows in cold temperatures, so it survives in unpasteurized dairy. There's soft cheeses, cold deli meats, all that stuff. And the high-risk patients are going to be pregnant women. I would say 9 times out of 10, that's going to be your demographic. Also, like, neonates, elderly, immunocompromised, but for some reason on STEP, they just love asking about the pregnant woman. And so in pregnancy, you have like mild flu illness in the mom, but it can cause chorioamnionitis, fetal demise, neonatal sepsis, meningitis, all that stuff. Okay, here are the explanations. Raw poultry is Campylobacter risk, smoked salmon, less likely for Listeria. With diarrhea, Shigella, but they're the blood, you'd see tons with Shigella. Farm animals, E. coli associated. So Listeria likes lunch meat, that's how you remember it. This next one is one of my favorites for some reason, WADA syndrome. The pathophys is you have a pancreatic islet cell tumor. VP binds intestinal epithelial receptors, increases the CAMP, chloride, sodium, and water secretion. You get just tons of watery diarrhea, and it inhibits gastric acid. You treat it with somatostatin. Labs, low potassium, low chloride, high bicarb, increased VIP. Octreotide inhibits VIP secretion. So here we have a 46-year-old woman, could also be a dude, as in her demographic there. Progressive fatigue, lightheadedness, and 6 days persistent profuse watery diarrhea is what we're thinking of, and so you give somatostatin analog. Here are the trap answers. Pancreatic enzyme, that'd be for steatorrhea, non-secretory diarrhea. Loperamide is an opioid analog, different mechanism. Insulin infusion for hyperglycemia or DKA. H2 receptor antagonism is for acid suppression. So yeah, a rare pancreatic tumor is what this person's got. You can actually cause up to like 3 liters of watery diarrhea. So it's just like profound watery diarrhea. So you also get hypotension, hypokalemia. The stool output is like 3.5 liters a day. It's associated with MEN1 syndrome, arises from the pancreatic tail, octreotide. Flush face, watery diarrhea, hypochlorhydria, or achlorhydria, and hypokalemia. It's a VIPoma, pancreatic neuroendocrine tumor secreting the vasoactive intestinal peptide. All right, next, what's the swelling that enlarges with crying? Indirect. It's a communicating hernia. Soft reducible mass in the groin, lateral to the inferior vessels. This is going to be seen in kids. I remember that because KID, kid, I, indirect. Processus vaginalis fails to obliterate, leaving a pathway, and then the abdominal contents herniate in there. It's indirect. So it could be a super youngster, like this cute little baby on the top. And so here's our question. 2-month-old male evaluated for swelling of his left groin. The parents notice during diaper changes. Swelling enlarges when the child cries and disappears when he's calm. On examination, a soft, non-tender, reducible bulge is noted on the left groin. What's going on? It's lateral to the inferior and superior to the inguinal ligament. Indirect. What about all these other answer choices? Well, we kind of got to know them. Inferior to the inguinal is femoral. That's in women. For step 1, just think it's in women. They're not going to test you on harder than that. Superior to ligament, direct inguinal in adults. Medial to the vessels, not going to see anything there, especially not above the transversalis fascia. Femoral canal, lateral, again, femoral hernia territory. So we got a young kiddo and a groin bulge that worsens whenever they cry and it goes away whenever they're resting. Indirect inguinal hernia every single time. It's the failure of the processus vaginalis to close. And the anatomy is the indirect inguinal hernia. So it'll pass through the deep inguinal ring into that canal in the superficial ring, so it can even reach the scrotum, and it's lateral to the inferior epigastric. Remember, MDs lie, medial direct, lateral indirect, lateral to the inferior, and it's superior to the inguinal ligament. And so a direct inguinal hernia is medial to the inferior epigastric through the Hasselbalch's triangle, and the femoral hernia is inferior to the inguinal ligament. All right, so it's all about that inguinal ligament, right? If it's medial to the inferior epigastric, then it is a direct inguinal hernia. If it is lateral to the inferior epigastric, then it is an indirect hernia. Remember, MDs lie, lateral, indirect, medial, direct. Older people, kids. Done. All right, let's talk about PPAR-Y, the party. For those of you who have gone to parties, I've never gone to a party before, but I hear they're fun. We have a 54-year-old woman, could be a man as well, so check our demographic image here. Could be either. 6-year history of type 2 diabetes, follow visit. Blood glucose remains elevated despite maximum doses of metformin. And we're now going to try a medication that improves insulin sensitivity by binding to a nuclear receptor. 1 month later, we have mild weight gain. Which drug and mechanism of action? Peroxisome, proliferator, activated receptor gamma. I have a video on all these drugs, but here we got, the way that you'll see this on test day is somebody's going to have type 2 diabetes. They're going to be on like glyburide or sulfonylurea and metformin, and they're still not going to go anywhere with it. The next step after you've tried a glyburide like sulfonylurea or metformin, you're next going to go to pioglitazone. The mechanism there is very clear. It's you need glitter to go to the party. That's how I remember it. So glitazone to go to the party. Okay, so it binds the PPAR. It binds the PPAR gamma, and I like to say the gamma is like a Y. Glitazone, glitter to the PPAR-edy. Peroxisome, proliferator activated receptor gamma. That's what it stands for. So the PPAR gamma is a nuclear transcription factor that's found in the adipose muscle liver. And the activation increases the gene expression for the insulin sensitivity. And so you have better glucose uptake by the muscle and the fat. And then you have decreased hepatogluconeogenesis. It's not a GLP-1 agonist like liraglutide that increases insulin secretion and decreases glucagon. So you remember glitazone, or you can remember P for PPAR-E and P for pioglitazone. But yeah, either way, that's for peripheral sensitivity. Now let's look at these explanations. Activates PPAR-Y, edema weight gain. AMPK would be metformin. DPP-4 inhibition, sitagliptin. SGLT2 flows in the liver, promotes glucosuria. Potassium channel inhibition, sulfonylureas, causing insulin secretion. Cool beans. All right, now this is about where I was when I lost the recording last time, but there's a really easy hack for this question. Basically, if you see an African-American individual or somebody from the Southeast, kind of Asian descent, it's like maybe a sailor, they get lots of sun, but they don't sunburn is the point. So dark skin has like protective melanin, right? And so basically they would be at melanoma risk. And in darker skin, the UV-related melanomas are like less common, right? Because melanin is protective. And so anytime you see that kind of scenario forming on your question stem, immediately lock in acral lentiginous melanoma. That's a darker linear streak on the nail beds in patients with darker skin. And that's how they're going to test on test day. I know it is what it is. The classic sites are going to be the palms, the soles, and the nails. And it's most common in African-American and Asian patients. That's just how it is. That's how they test it. And like other answer choices like the chest, forehead, all that stuff, those are like sites for UV-related melanomas and superficial spreading and not lentigo maligna, but that's less common in darker skin. So the darker skin really lends you more toward the acral melanoma. All right, now this one is wild because almost as soon as I recorded this, I went out and bought this mouse so I could make better videos for you guys on Facebook Marketplace, and I met somebody who had this condition. She literally told me that she had acute inflammatory demyelinating polyradiculopathy, and I was like, that is a mouthful, and also that was the first time I'd seen a patient with that. But anyways, 35-year-old woman, 4 days progressive weakness, difficulty climbing, tingling in her toes, episode diarrhea after eating undercooked poultry, lumbar puncture reveals elevated protein with white blood cell count, answers antibody mediated demyelination of the peripheral nerves. So yeah, this is kind of pointing at Guillain-Barré, but like specifically the acute inflammatory demyelinating polyneuropathy. And so it's post-infectious. autoimmune cross reactions. The antibodies attack the myelin of the peripheral nerve roots, and demyelination slows the conduction time. So polio, anterior horn is poliomyelitis, not ascending, asymmetric spinal atrophy of the muscles, axonal, corticospinal loss, and ALS. Postsynaptic acetylcholine is myasthenia gravis. Or what's interesting is that Guillain-Barré is the most common cause of acute flaccid paralysis in the United States today. It's not polio, it's Guillain-Barré. Okay, this next one, I'm not going to overcomplicate it. It's basically if somebody has vaginal dryness, they're going to have low estrogen. So this is always obviously going to be a female, but like maybe think of postpartum breastfeeding, dysuria, pale, dry vaginal mucosa 5-6 weeks out. Lactation causes increased prolactin that inhibits the GnRH, that inhibits downstream later on estrogen. And the mechanism is important. It's low GnRH to low FSH to low LH to low estrogen. But then here in our practice question, we have elevated prolactin, and that's what's causing the estrogen that's low. Menses have not resumed since delivery. Low estrogen is definitely going to be correlated to vaginal dryness. All right, here are the other answer choices. Increased luteinizing hormone would be PCOS, but here it's lactation, so this is suppressed. Decreased prolactin impairs milk production. That would not cause pain during sex. Increased estrogen. So yeah, breastfeeding mothers can experience vaginal dryness. And this isn't because of menopause at all. This is like prolactin stuff. In fact, it might explicitly test you on patients who are before menopause just so that they can get at the prolactin's effect on the lowering of estrogen. But yeah, it's an interesting mechanism. Got to know it. All right, on to our next one. Here we have a 65-year-old man, a 5-year history of poorly controlled hypertension, and they're going to give him a CPAP, and it's going to say, hey, what's going to change? It's going to be a reduction in your blood pressure. And that's interesting. But, usually the way they'll ask it is we got like some patients, usually it's going to be like kind of obese, loud snoring, daytime sleepiness, obstructive sleep apnea, all those symptoms, OSA, and hypertension, diabetes, kidney dysfunction, all that stuff. And they're treating with a CPAP. Basically on OSA, which is obstructive sleep apnea, you have repeated airway obstruction at night, and you have drops in the O2, and that causes sympathetic surges. And so the sympathetic surges cause a big swing in the blood pressure, and that's sustained in daytime hypertension. And so CPAP prevents the airway collapse, and that reduces the apneic episodes, and that lowers the blood pressure. And it's not going to be the pulse, because that's not consistently lowered with CPAP. Creatinine. So sleep apnea can worsen your chronic kidney disease, but the CPAP doesn't fix it, so that's not going to be the answer. Here's some good answer choices that you can choose between. Uric acid would be gout associations, not CPAP related. Renal dysfunction is elevated creatinine, but not with the CPAPs. Weight loss, CPAP alone does not cause weight loss. Glucose, CPAP helps insulin sensitivity modestly, but does not normalize it. All right, next we're going to talk about immunoglobulin switching. Isotype switching happens after the antigen stimulation. So you got the heavy and the light chains, and they each have variable regions. So there's the variable region is what you should know. And that's unique, right? It's unique for every antibody. It never changes even after the VDJ switching. And the constant regions are determined by the class, like IgM, IgG, IgA, IgE, IgD, and the isotype class switching that happens after antigen exposure with help from the T cells. So you have CD40 ligand, cytokines, and the constant region of the heavy chain gets swapped. So IgM to IgG. And the variable region, that stays the same. The constant region are the parts that change during the isotype switching. So here's our question. 24-year-old man has a vaccine composed of an activated virus. 2 weeks later, serum shows high levels of IgG specific to the viral antigen. This process involved genetic recombination of which portion of the immunoglobulin molecule? It's the constant region, because class switching involves the constant one, like going from IgM to G, while preserving the VDJ recombinated region, allowing the B cell to retain its antigen specificity while gaining the effector functions. All right, those are the other answers. But yeah, every single antibody that you have or that you make after vaccine starts with an IgM, even the IgG and the IgAs. All right, guys, we're almost there. We are so close to the finish line. All right, so here we have a 22-year-old college student who is confused in her dorm room, multiple empty cold medications nearby. Vitals are stable, but look at that, 2,100 AST, ALT 2,250. What's the mechanism of this hepatotoxic effect? It is lipid peroxidation due to the oxidative free radicals. This is acetaminophen overdose. Accumulation of NAPQ toxic metabolite. Glutathione is depleted. NAPQI causes lipid peroxidation and death. So acetaminophen overdose is actually the most common cause of acute liver failure in the United States. And usually they have like a normal exam. The questions they like to ask this is like a younger student in college or somebody else, but typically at normal doses, it's safely handled. This medication is safely handled by the phase 2 conjugation, like glucuronidation or sulfation. But at overdose, you get some saturation, right? You get excess acetaminophen that's shunted to the CYP450 metabolism. And so CYP450 makes NAPQI, right? It's a toxic metabolite. And so what that does is it's normally detoxified by glutathione, but in overdose, glutathione storage gets depleted. And so now you have a lot of NAPQI, and you get peroxidation of the lipids in the cell membranes. And the treatment is N-acetyl cysteine. That's the secret. All right, last question, and I really worked this one up. Basically, we have a 72-year-old man or woman, as you can see in this demographic image. It could be either. And the reason I'm trying to do that is I want you guys to be exposed of not just locked into this one patient. I want to give you a range of the demographic that's affected, because I think that's helpful as you take the step 1 exam to think about what types of patients you can and cannot see, as opposed to just being like, oh, it's a woman this time. I want it could be a man. But here we're kind of testing like some myocardial problems like congestive heart failure stuff. And so it's going to be somebody elderly. But I digress. A 72-year-old woman, in this case, history of long-standing hypertension, presents with progressive dyspnea and orthopnea. We have a normal left ventricular ejection fraction, but increased left atrial size and signs of impaired diastolic filling. Myocardial biopsy reveals normal sarcomeric structure, but increased systolic calcium levels during diastole. Which of the following mechanisms is most likely impaired in this patient's cardiomyocytes? The answer is the function of the sodium-calcium exchanger. That's diastolic calcium clearance. Now, especially if we look at heart failure with preserved ejection fraction, we have that poor myocardial relaxation, not the poor contraction. Contraction's fine, it's just the relaxation's not. So you preserve the ejection fraction. We have a circa dysfunction in chronic congestive heart failure. So it's the inability to restore the low calcium concentration during diastole. So basically what's happening is like after contraction, the calcium is not cleared from the cytoplasm. And so you can't relax. You just can't relax. There's so much in the body that's like that. You just can't let go. And after contraction, the calcium must be removed. It has to be. And that's mainly done by what? How is this done? By the sodium calcium exchanger. It pumps the calcium out in exchange for the sodium to come in. And that's how you restore the baseline before you can actually start the next beat of the heart, right? It's not the fast sodium channels, because what do those guys do? The fast sodiums, those are the depolarization, right? That's phase 0. That's the fast depolarization. Inward rectifier potassium, that stabilizes the resting potential. L-type calcium channels, that lets the calcium in, right? That's the phase 2 plateau. And then ryanodine receptors, that releases the calcium to trigger that. So the ryanodine release, it's the sodium calcium exchanger. That's what's happening here. All right, guys, we did it. Man, deja vu. It's been fun kind of doing this twice. I've actually gone through and finished all the way to 90. So I'm going to try to finish the rest of these as soon as possible. If you guys like this format, please let me know. Is that better lighting? Let me know as well. Should I have all of my lights on, or is this better? Anyways, I hope you guys are doing super well. And remember, you're going to pass this exam in due time. Take care of yourselves. No feeling that you have is final. Make sure to prioritize your mental health. And let me just show you guys something. You live in a tiny little blue dot. That's you. And all of your problems, they seem like they're the biggest in the world, but that's only because of your perspective, right? We don't have control of very much, but a change in our perspective is very easily accessible through meditation and gratitude. So remember, if you're feeling a little bit overwhelmed, take a pause before watching the next little couple videos. Watch a movie, do something that's fun for you, lift your calcium oxalate dumbbells. And remember, we don't have a lot of time here on Earth, so make the most of it. We'll see you guys in the next video. Adios.